happens when you are such a case for exam. So how to take history, what all the things to be taken in the history and examination, especially the difficult airway examination, and conclude, so that we will know how to go ahead and then manage these type of difficult airways. Okay, you just presented.
Start, sir. A 25-year-old male patient, chemical factory worker by occupation at Pondicherry, came with chief complaints of excessive postbone scarring at lower part of chin, anterior and lower surface of neck, upper chest and right upper arm for past 18 months. Grossly restricted neck movements with inability to look upward, and mouth opening is limited. History of presenting illness. Patient was apparently normal prior to the fire explosion accident at workplace 18 months ago. After that, he developed burn, which involves lower part of chin, neck, chest, and arm, accounts approximately 30% of total body surface area. Initially was managed for a week in high dependency unit and latent burns unit, and finally discharged after 25 days of treatment. History of HDU admission and acute management of burns was present. Gradually, he developed scarce tissue formation over lower chin, neck, and upper chest and right arm, with restricted neck movements and limited mouth opening. History of weight loss of 10 kg over 3 months. No history of stridor or suit to the sputum, respiratory distress at the time of sustaining burn injury. No history of voice change, dysphagia or aspiration at the time of sustaining burn injury. And no history of any airway intervention at the time of sustaining burn injury or tracheostomy at latter part. Past history, patient has no comorbidities. Personal history, diet, mixed diet, ex-smoker, smoked 5 years ago prior to incident, smoking 1 packet per day, no other addictions. Appetite normal bowel and bladder habits. Sleep, patient sleeps in lateral position with a pillow and rest neck. Family history nil significant. Treatment history, no other relevant medical or surgical history.
The general and physical examination, sir. The patient was conscious, oriented to time, place, and person. He was comfortably sitting with no signs of any respiratory distress, and he was thin built and was averagely nourished. Patient weighed around 50 kgs and height was around 165 centimeters with a BMI of 18.4. No signs of pallor, request, clubbing, lymphadenopathy, or edema. And IV access was present, and vitals showed a pulse rate of 72 beats per minute, right radial in the regular rhythm, moderate volume, and arterial wall was well palpable. No radio or radiofemoral delay, and all peripheral pulsations were felt. The blood pressure was 120 by 70 millimeters of mercury in the left, recorded in the left arm in sitting position. Respiratory rate was 14 per minute, and breath holding time was 35 seconds. Saturation, patient maintained 98% on room air. The airway examination, interincisor distance was 3 centimeters. Modified Mallampati score grade 4. No loose or missing tooth. Thyromental distance could not be measured, and sternomental distance was 8 centimeters. An upper lip bite test was grade 3, and the patient was unable to protrude his mandible. And the temporomandibular joint, patient was unable to insinuate one finger. Was not unable to insinuate one finger in front of the tragus. Nostrils, both nostrils of normal size and patent. The difficult airway Lemon score was 7, including the Mallampati was 7 by 10. And local examination, inspection, burn scar present over the lower part of chin area, front of the neck, and lateral to the medial part of sternocleidomastoid and upper chest and right arm. Circumferential scar was present, involving approximately 50% of the anterior aspect of the neck, and scar was also involved in the upper chest above the nipple line. And left side clavicle was visible, and 1/3 of right clavicle covered with scar tissue. There are 3 strong visible bands of scar tissue starting from the mentum to the mammary region, and no active ulceration, sinus, or fistulas were present. Thyroid, cricothyroid membrane, and trachea were not visible. Palpation, scars not tender, firm, and raised above skin surface. Sternal notch was able to be palpated. Thyroid, cricoid, and cricothyroid membrane and trachea could not be palpated. Carotid pulsations were felt. Systemic examination. On inspection,
no important this thing. You can just say no abnormal.
Respiratory system is normal, sir. Cardiovascular system, no S1, S2, no abnormal sounds.
Okay.
CNS, higher mental functions are normal. So summary: a 24-year-old male patient with post-burn contraction over lower chin, neck, upper chest, and right arm, with 18 months duration, with a difficult airway of Mallampati grade 4 and Lemon score of 6 by 9. Scheduled for elective contracture release.
Okay. So let us just, in your history, one thing is very important here. You have written that this patient sustained burn injury about 18 months back. So why this duration of burns is important for you as anesthesiologist?
So with increase in the duration, the more difficulty the airway becomes, sir. And also for
No, airway can be difficult even initially also, many times. If they have sustained burns even to the face, you will not be able to even place an,
mask.
mask also, or very difficult it will be. So,
So for succinyl
difficulty will be throughout. Yeah.
For succinyl choline duration, for giving succinyl choline,
for us anesthesiologists, because many times you will have to give general anesthesia for these patients. Whenever you want to give general anesthesia, one major problem is regarding the use of succinylcholine. Okay, so Arvind, you are talking about succinylcholine. What are the problems with succinylcholine as such?
So normally in burns patient, there will be proliferation of extra-junctional receptors. Sir. This lead to extra proliferation of potassium. This lead to hyperkalemia. Sir. So compared to normal patients, the burns patient will have more hyperkalemic response, like increasing 0.8 to 1.4 milliequivalents per liter. It may go up to 13 milliequivalents per liter.
So why these extra-junctional receptors are formed in burns patients?
So,
why it has to form at the neuromuscular junction, other than the neuromuscular junction? That's why they are called as extra-junctional. Throughout over the muscle membrane, these receptors can develop. Normally, over the muscle membrane, you don't have receptors. It is usually junctional receptors, but during burns, these extra-junctional receptors can form. So why they form actually?
It is because of the decrease in the intracellular protein rhabsin, sir.
No. Why? Why the body? Body, it's a defense mechanism for the body. No, okay, I'll give you a clue. For example, now if there is a nerve injury, a motor nerve injury, again, there will be extrajunctional receptors are formed, isn't it? So why their extrajunctional receptors are formed whenever a nerve injury?
so
Even in
loss of muscle power.
No, even nerve injury also, even whenever the burns occurs, nerves also can get damaged, isn't it? So once the nerves get damaged, so body will try to increase the number of receptors so that whatever the acetylcholine that is released can act on more number of receptors. It is like denervation it is called as denervation supersensitivity. That is the correct, the nomenclature for this. And also, it can also be called as an upregulation. For example, now you are using a beta blocker. So whenever you are using beta blocker and suppressing the beta receptors, there will be upregulation of the receptors, isn't it? That's how, rebound phenomenon will occur if you stop the beta blockers suddenly. So same thing here, denervation supersensitivity, whenever nerve damage occurs. So at the neuromuscular junction, so body tries to increase the number of receptors so that acetylcholine can act on more number of receptors. Body thinks can act on more number of receptors and can produce a better contraction. That is the idea of extrajunctional receptor formation. Okay, usually you will be asked about this particular thing whenever you have a burns patient. What is the difference between junctional receptors and extrajunctional receptors? How do they differ anatomically and how do they differ functionally?
Extra-junctional will be present other than neuromuscular junction, like other periphery.
No, that is their positioning. That is why you call them as extrajunctional. Their anatomy actually of the receptor itself.
So that alpha subunit will be.
No. What are the subunits in a junctional receptor? Normal junctional receptors. How many subunits are there?
5, sir.
5. What are these?
2 alpha.
Yeah, 2 alpha.
2 alpha, 1 beta. Gamma. Sir.
No. 1 delta and 1 epsilon.
1 epsilon. Delta and epsilon.
And epsilon. Whereas the extrajunctional receptors, what happens?
Alpha subunit is.
No, delta subunit is replaced by gamma subunit. Instead of delta, there will be gamma subunit will be there. So that is the only difference in the extrajunctional receptor as far as whenever a burns occur or denervation supersensitivity occurs. So what is the functional difference here? This is the anatomical difference.
Yes, sir.
Why hyperkalemia occurs? What is the functional difference?
Sir, increase in the number of receptors, sir.
No, that is what increase in number of receptors, extrajunctional. The whole surface of the muscle will be filled with now extrajunctional abnormal receptors are there. Now, one thing is, they keep open for a long time. That is one problem with these receptors. When compared to the junctional receptors, they open for a very short time, but the extrajunctional receptors will keep open for a longer time so that more amount of potassium can come out. That is one functional difference. Second functional difference is that they can even get opened with choline itself. Acetylcholine is not required. Even just choline itself will open them. They are extremely sensitive for choline also, and also succinylcholine. Succinylcholine, because it is a 2 molecules of acetylcholine. So they open, and they open for a longer time. And because of that, more potassium will come out. And what is the life of junctional receptor and what is the life of extrajunctional receptor? How long they can live, whereas how long junctional receptors can live?
So life of extrajunctional is short, like 24 hours.
Yeah, that is 24 hours, whereas junctional receptors?
7 days.
7 days. Oh, you're guessing correctly.
I don't remember properly, sir.
Okay. Anyway, but when you are presenting burns, so this is because for us, this is one of the most important things regarding use of succinylcholine. Should we use or should we not use? Isn't it? So the duration of burns becomes very important. So from what day to what particular duration, you don't use succinylcholine because
This percentage of burns is less than 40%. We avoid for 180 days.
No, from
40. It's 40 after 48 hours to 180 days. Acute burns we can use.
Yeah, from second day onwards, because there should be sufficient time for the extrajunctional receptors to form, isn't it? So after once, that is usually about 2 days. Usually from second day onwards, you should be very careful. So usually we used to say that up to 6 months, you try to avoid succinylcholine. But in the older books, if you see up to 2 years, yeah, you should avoid succinylcholine. So because in your patient 18 months, and another thing is why 2 years? When you can still wait up to 2 years before doing
percentage of burns more than 7.
No, percentage of burns already you have told that unless it is more than 50-20%, you still can use succinylcholine. But what is more important is whether the burns has healed completely. If the healing is not completed, even after say 18 months or 19 months, you are not supposed to use. But if it is completely healed, so after 6 months, there is not much of a problem. You can still use, provided you also think about the benefit and risks of using succinylcholine, even after 6 months up to 2 years. If you think that the benefits are high, extremely difficult airway probably, and you require to use succinylcholine and then intubate, so then you have to be careful. So that is what. So risk-benefit ratio you'll have to think about. So the other important thing about is the assessment of burns. So that is what you have written here. So how do you assess the burns usually? What is Wallace formula?
So the body surface area that has been affected by the burns.
Yeah,
so
that is what.
On the head and neck region, we give around 9%. 9%.
That is rule of 9 of Wallace.
It
just tell about the 9, all the 9s.
Head and neck 9, sir.
Okay.
And anterior posterior upper trunk, it is 18%.
9% always you tell.
9%.
So head is 9%.
Head is 9.
9, yes, sir.
The posterior part of the chest again is 9%.
9%.
Abdomen is 9, and posterior back is 9%.
Very good. Then
and leg is anterior aspect is 9, and posterior aspect is 9. On the other side of the leg, anterior aspect 9, and the posterior aspect 9, and perineum
1%.
Okay, so that is what and arm, the upper limb, and again each upper limb is 9%.
Each upper limb is
9%.
So this is how we usually check for this thing. And why do you have to check for the extent of burns?
Fluid calculation, resuscitations.
One is for resuscitation fluid calculation. Then
And we can calculate the degree of burns, like first.
no, to know whether it is a major burn or
burns.
minor burn. When do you say it's a major burn?
More than 30%.
No.
Like
No, it again depends
chemical
on what is the
injuries.
extent of burns also. Yeah, chemical, electrical, inhalational burns are major burns. Okay. Then which part of the body again?
So like head and upper limbs.
Head and neck, yes, one. Then hands. Yes. Then perineum. Isn't it? So these are the major burns, plus the extent of the burn, whether it is type of how much of the dermis epidermis is involved. That is also very important. If it is a full thickness burn of more than 10%, and if it is a partial thickness of more than 20%, is called as a major burn. Now, for that, you will have to classify these the burns also, whether it is superficial.
First degree, second degree, or third degree burns.
So how do you classify these burns?
So the first degree burns is regions covering only the epidermis region of the skin.
Yeah, that is also called as a superficial burn.
Superficial burns.
Okay.
Second degree burns is up to the dermis level, and more than 25% of body surface in normal adults, or more than 20% body surface in elderly people, sir. Old age.
Again, you classify it as
superficial, partial, and superficial.
Yeah, superficial, partial, and deep partial, isn't it? So that is what is superficial partial and what is deep partial?
So it will involve half of the portion of epidermis, sir, and deep partial 1/3.
No, full epidermis and 1/3 of the dermis in superficial partial thickness, whereas now deep partial thickness is complete epidermis and complete dermis. And then third degree burn is full thickness burn, including the deeper tissues also get burned. So this is another very important thing they may just ask you. Okay, when you have these burns, these patients may come for, or you may require to assist the management of these patients in many of these occasions. Like one is that for resuscitation you may be required of these burns, or when they come for eschrotomies, they may come, say after 1 week or so, or they may come for excision and skin grafting, they may be coming, or they may be coming for repeated bones dressing to the OT, and you'll have to give anesthesia, or they may actually also come for late is for the excision of the contractures. Also they may be contracture release, also they may be coming. So these are the different times when, as anesthesiologist, you will be involved in them. So first thing is for resuscitation of the burn. So when you are called in to resuscitate the burns patient, how are you going to resuscitate?
So normally we used to first check for the ABC, airway, breathing, circulation type.
So first you assess, isn't it? Assess the amount of burns. Once you assess that the burns is quite significant burns has occurred, now you'll have to think that you require to resuscitate this patient. So, okay, one is, as you said, that airway and breathing.
It is better to secure the airway before itself, sir, because the edema will start after 24 to 48 hours.
No, which kind of patients require airway management, early airway management?
Inhalational
burns. Patient presenting with wheeze, spasms, stridor, and all.
So, inhalational burns and also burns of the face. Yes. If the patient has had a burns of the face and neck, so which probably might produce edema of the upper airway and then can produce total blockade of the airway. So it is always better to secure the airway before actually the edema sets in. So that's how airway breathing will be very important. And then third, you are talking about circulation. So what is this circulation? Why should you assist their circulation?
So due to the capillary endothelial damage, the more leak will be there. So patient will be more hypovolemic.
Okay.
So we have to ressuscitate. Because of the cardiac output and perfusion and all will go down, and the renal hepatic shutdown will happen. So we have to resuscitate. So according to
quite a bit of dehydration they'll develop. isn't it? Because of increased capillary leak, they'll have a lot of dehydration. And also they may be going in for acute renal failure also because of this pre-renal failure. So you have to really resuscitate. So how do you resuscitate? Usually there are so many formulas are there. Which formula you'll be using in majority?
Parkland formulas.
Okay, what is this Parkland formula, which is very popular, which is
The
a
fluid
simple
is
form?
finger lactate, sir.
Okay.
4 ml per percentage of body surface area
Per kg.
and into weight for 24 hours, sir. And 50% we will give in initial first 8 hours, and the balance 50% we will give in next 16 hours.
Okay, okay. So that is what, invariably this particular question in resuscitation, especially regarding the fluid resuscitation, you will be asked. And the second day of Parkland formula, you will be going in for
Colloid, sir.
Colloid.
0.3 to 0.5 per kg body weight.
And also
With
blood.
along with dextrose we have to use.
And you can also give blood transfusion also, if required, if the patient's hemoglobin has dropped. Initially, they'll have hemoconcentration, and afterwards, they'll have severe anemia. In such situations, you may have to go for definitely blood transfusion also will be required in these patients. So, okay, now let us say that these patients come for eschrotomy. So, what are the important concerns for you as anesthesiologist when they come for eschrotomy? You know what is eschrotomy? After about a week or so, eschar is formed, and that has to be taken out. Otherwise, the burn healing will not occur. Superficially, it will form. So that is called as eschrotomy. So what are the concerns when these patients are posted for eschrotomy?
These patients mostly will be like anemic due to that undehydrated.
No, you would have resuscitated them. They'll not have dehydration now because it usually after about a week, they'll be coming for eschrotomy. Invariably, they'll not have any dehydration as such. That is only initial for first 48 hours, that resuscitative phase. Afterwards, they'll not be in the resuscitative phase. So when they come for eschrotomy, when eschar is removed, large surface area is exposed. One is they are highly likely to develop hypothermia. Hypothermia is a real concern because you'll not be able to cover that amount of area which the surgeon will be operating upon. The second thing is, the bleeding. When they take out the eschar, there is a lot of bleeding occurs. And it has been said almost about 200 ml for every 1% body surface area that is eschar is removed, that amount of blood loss can occur. So you may not be able to assess the blood loss because the blood will be oozing from all the surface of the body, the skin. So very difficult to assess the amount of blood loss, and invariably they'll go for severe anemia and shock very rapidly. So that is why, second problem other than hypothermia is blood loss. The third thing is the airway problem. So in these patients. And fourth is use of succinylcholine. So you'll not be able to, because they'll usually come after about a week. So you'll not be able to use succinylcholine. So that is another problem is also there. So the other important thing again here is the monitoring. Because if the extent of burns also includes the upper limbs, the chest, it's extremely difficult to use your ECG electrodes and your sphygmomanometer cuff. So in such situations, how are you going to monitor these?
Stapler needles like ECG is this.
Yeah, you may require to go for a needle electrode. Separate needle electrodes are available. So that is one.
For an invasive BP monitoring or a lower limb, if lower limb is free of burns, we can go for lower limb BP, or invasive BP monitoring we can use for BP.
Invasive many times, because invasive monitoring may be required because I told you that they bleed a lot, isn't it? And that is another very important thing you'll have to think about. And third is, I was telling you about hypothermia. So
you have to cover the non-exposed in the areas which are not doing surgeries.
Usually, hypothermia occurs because what are the different mechanisms by which a person loses the temperature?
Conduction, convection, evaporation,
and
radiation.
What is this conduction?
So the surface touch to the body.
Yeah, direct transfer of heat or the temperature from the patient's body surface to the place where his body surface is in contact with. For example, the table, the bed. So it can directly, that is the reason we always use a thermostatically controlled bed many times when they are made to lie down, so that conduction heat loss is prevented. So what is convection? When cold air passes over the skin, so it takes away the heat or the temperature from the patient. That is why, very important that you use hot air to in front of or over the patient's surface many times to prevent these convection currents. And then evaporation.
So normally the patient, the atmosphere.
No, when you open the body surfaces, body cavities, I mean. So directly the temperature can be lost through the body cavities, that is evaporation. And also when the surgeon uses these cold solutions, antiseptic solutions on the surface. So usually these solutions evaporate fast. And also, for example, spirit, if he uses. So spirit evaporates and takes the temperature also of the surface. So that is evaporative loss. And radiation.
Exposure.
What is radiation? And it is most important. Almost 40% of the heat loss that occurs in the operation theater is because of radiation. So radiation is, temperature gradient from the environment to the body. If the outside temperature is very low and, the patient under anesthesia, so what happens is temperature from the body will start moving out, because, these anesthetized patients behave like poikilothermics. That means, they try to equilibrate their body temperature with the environmental temperature. Anesthetized patients, because there will be inhibition of thermoregulatory center also by our anesthetics. So that's how, heat loss starts occurring to the environment. And the OT temperature becomes very important in such situations. If the OT temperature is very low, rapidly the heat loss occurs from the body. So through the radiation heat loss. So you must have heard about radiant warmers for babies, isn't it? So the temperature around the baby is very high, so that radiation loss, which is the most important loss of temperature, does not occur. So that is another very important thing. What is the OT temperature you will be keeping for patients?
28.
Yeah, usually about 23 to 28 degrees centigrade. So this is another thing. And also continuously you have to monitor the temperature, isn't it? So these are some of the important things when they come for ischiotomies. Okay, so the other thing is they may keep coming for burns dressing, isn't it? Every alternate days they may be brought for dressing of the burn wound. So how do you anesthetize these patients when they repeatedly come for burns dressing? Because it may take maybe about half an hour maximum. They'll just remove all the older dressings and then apply some ointment or some antiseptic cream, and then again put the dressing again.
Opioid you can short.
Only opioid is sufficient?
High flow nasal oxygen thrive method.
Pardon?
High flow nasal oxygen.
Thrive is only for oxygenation. It is not for analgesia. No, for burns dressing you have to give analgesia.
Opioid with thrive.
No, opioid is fine, but opioid alone may not be sufficient, because opioid is ideal for, already we discussed, it is mainly for, the sympathetic mediated pain, the C fiber pain, not for somatic pain, isn't it? So you have to give majority of the times the anesthesia also. So one of the ways of giving anesthesia for these patients is holding a mask with inhalation anesthetic, or even putting a supraglottic airway
with inhalation,
allowing them to breathe spontaneously with inhalation anesthetic agents, plus opioid, of course. That balanced analgesia you have to give. Or otherwise, best thing would be many times these patients are given ketamine.
Ketamine.
Yeah, just about a combination of ketamine and opioid. Ketamine, of course, when you give ketamine, you have to give an anticholinergic, and also you'll have to give midazolam.
That's all.
And 0.5 milligram per kg body weight to 1 milligram per kg body weight of ketamine. You can keep repeating the doses of ketamine with oxygen supplementation using a mask. So in the older days, we used to use halothane. So what was the problem? Sometimes you may be asked.
Arrhythmias.
Repeatedly, if you use halothane, what was the, no, of course, that sensitization of the myocardium for dysrhythmias is there.
Hepatitis.
Yeah, usually it was said that if you use halothane, you cannot repeat the halothane again after how many days, usually. Because one of the risks for halothane hepatitis is repeated use of halothane. Because you will sensitize these patients, because immunological theory, there are two theories for halothane hepatitis. One is immunological theory, another is a metabolic theory. So as far as immunological theory, once you expose them, they get antibodies are formed, that is haptins. And repeatedly, if you expose, so naturally there is increased incidence of hepatitis. So usually what was taught, like after one exposure, the repeat exposure should not be, what should be the interval?
4 months.
Usually 28 days, repeat exposure. So, but in burns patient, they have used repeatedly and the patients have not developed any kind of halothane hepatitis. That has been seen, but usually in the exam, they may be asking this particular question because many of us would have used halothane extensively for these burns patients, because nowadays you can use sevoflurane, isn't it? So in our days, sevoflurane was not available, only halothane was available in the olden days. So majority of the times we used to use halothane. Okay, now these three are invariably they can ask you. One is for eschrotomies, another one is for burns repeated dressing, and another thing for resuscitation if the patient has been brought to the medical inspection room and you are asked or the emergency room. So the other thing is they may come for skin grafting also, isn't it? So you might have given many times anesthesia for skin grafting. So what are the concerns when they are posted for skin grafting? Anesthetic concerns.
Like difficult areas.
One is because the skin grafting will take longer time or shorter time, or
Longer duration.
yeah, longer time they may take. So one is, as you said, the difficult airway. Okay, then
Blood loss.
yeah, blood loss, because again all this eschar they have to remove and they have to do some wound debridement also, and they have to place. And what is the third problem? Hypothermia. So again the same thing like eschrotomy. So here usually the for skin grafting, skin is taken from which area?
Inner side of thighs.
Yeah, usually lower part of the body. So what anesthetic techniques you can use for skin grafting?
So if the graft they're keeping like lower side itself, you can go for regional.
No, for example, now this patient with a chest burns are there. This patient must have had repeated skin graftings also, because you have not examined this patient, but he would have told you if you have asked. He was taken to the OT repeatedly, and many times skin grafting was done for him. So usually for the chest, upper part of the chest.
General anesthesia.
So how do you go ahead and then, is it only regional anesthesia is sufficient? Now for taking the graft, regional anesthesia, definitely you can give a spinal or epidural, you can always give. For placement of the graft,
you should go for general anesthesia.
Again, you may have to combine regional anesthesia with general anesthesia, because again, taking the graft, it is afterwards it will be very painful. So that's how regional anesthesia with probably an adjuvant, analgesic adjuvant, if you are going in for a spinal, so would be sufficient for that pain in the post-operative period. Plus, of course, for placement of the graft, you have to go for GA. And again, all the problems of monitoring and other problems are always there. So these are some of the concerns. And now, presently, now this patient is being posted for neck contracture release, I think. That is what you have presented, isn't it? So with these, the introduction, now coming to the present case for neck contracture release. So you have examined his airway. So I'll just go with your assessment of the airway. So let us, because that is the most important thing in a patient who is coming for contracture release of the neck. Invariably, you will be asked a lot of questions on the airway assessment. Okay, so just let me, where is your, okay. So you have written about mouth opening 3 centimeters. So now what is the importance of mouth opening?
So
And how do you measure this mouth opening?
So the inter-incisor gap will be measured.
So suppose if the teeth are not there,
Upper alveolus.
interalveolar gap.
Interalveolus.
So if incisor teeth are there, definitely inter-incisor gap. If teeth are edentulous patient, interalveolar gap. So what is the normal this inter-incisor gap?
5 centimeters, more than 5 centimeters.
So why you have written it as 3 centimeters here? So what is the importance of having a restricted mouth opening, isn't it? It shows that there is some amount of restriction. So there is, it's only 3 centimeter gap is there. So what is this 3 centimeter?
It's difficulty in putting LMA. It's like we want mouth opening at 3.5 centimeters, but we can introduce.
Yeah, what
So 3 centimeter
all supraglottic airway devices?
Yes.
No, there are many different supraglottic airway devices which can be placed even with lesser than 3 centimeters. Can you just name a supraglottic airway device where even at 3 centimeters or even less?
Combi tubes.
Combi tube, we don't call it as a supraglottic airway device anyway, because we hardly use a combi tube. It's only for resuscitation.
LTS.
Yeah, you know,
Second generation.
No, they almost, the LMA which are supraglottic airway device which mimics a combi tube.
LTS.
Yes.
LTS.
Definitely. Laryngeal tube and laryngeal tube with suction. LTS is laryngeal tube with suction.
With suction.
Generation airway. And any other airway we can use in slightly restricted mouth opening.
Video larynx. LMAs.
Yeah, supraglottic airway device I was asking. So because most of the supraglottic airway devices can be introduced at 3 centimeters, 3 to 3.5 centimeters. So your this thing is 3 centimeters. So it is still it is okay. So another very important thing is if the 3 centimeter is there, so for you to introduce your laryngoscope, regular Macintosh laryngoscope, is it possible to introduce your regular?
Yes,
Yes, sir. The flanks of the laryngoscope will be like 2 point width of the.
Yeah, usually the flange is 2.5 centimeters. So 3 centimeter should be ideal. Even in this patient, you can even introduce a
direct laryngoscope.
Macintosh laryngoscope. Otherwise, if the interincisor gap is smaller, what laryngoscope you can use?
Video laryngoscope.
No, video laryngoscopes also have some amount of the flange will also be there. Which particular video laryngoscope you can use?
Bullards and Bonfils.
Yeah, Bullards.
Bullards and
Bonfils retromolar.
Yeah, retromolar also is a Bonfils, but the video laryngoscope.
McGrath and Glidescope.
The Bullards. Bullards
doesn't have a flange and only
even at interincisor gap of just about 1 centimeter also you can introduce. So that is why the interincisor gap measurement becomes very important. So the other thing you have written is about Malampati. How do you measure? How do you assess the Malampati scoring?
Sir, actually, this not the restricted mouth opening couldn't be assessed.
So one is restricted mouth opening. Otherwise, what is the position you make the patient to adopt for assessing the Malampati scoring?
So patient head should be in neutral position, sir.
Head should be neutral. Yes, very good.
And wide mouth opening without phonation, sir. And the observer should look the lower.
And what about the tongue?
Tongue maximum protrusion without phonation, sir.
Maximum protrusion or tongue should be placed within the oral cavity?
Protrusion.
Without phonation.
Maximum protrusion, sir.
Maximum protrusion of the tongue. So that is Malampatti scoring. So what is this modified Malampatti scoring?
Initially it was 3, sir. Modified it was Malampatti 4. Simpson has split into 4 classifications.
Not Simpson.
Yeah, Samson and Young.
Samson and Young.
Samson
and Young.
They added the 4th grade. Actually, it was only 3 grades. And already I was asking you about the full name of Malampatti. It's
Seshagiri Rao Malampatti.
Sheshgiri Rao Malampatti, Rao S. Malampatti. So that is, so Malampatti scoring, why it's important? What is its relevance actually?
So it gives us the approximate space to accommodate the laryngoscope and the ET tubes.
No. So actually, it gives you the relationship between the tongue size and the oral cavity size, isn't it? So it gives you how the tongue size and the oral cavity size, what is the ratio like? For example, if the tongue is big than the oral cavity, because when you are doing a direct laryngoscopy, it is the tongue which comes in your way of visualization of the larynx. So if the tongue is smaller when compared to the oral cavity, you can easily push the tongue away from your visualization of the larynx, isn't it? So that, tongue will not come in your way if there is sufficient room in the oral cavity itself. That is what, the Malampatti thought in the initial, time when he classified based on the relative size of the oral cavity to the relative size of the tongue. So that if the Malampatti scoring is less, like 1, that means the tongue is small and the oral cavity is big. That is what happens in case of preeclampsia. So the oral cavity starts decreasing because of the edema and the tongue size starts increasing. So relatively the tongue becomes too large to the size of the oral cavity. So you will not be able to push the tongue away from your view of the larynx. So that is the basic thing about Malampatti. And again, Malampatti scoring is always related to the Carmack-Lahane scoring, isn't it? Like Malampatti 1, Carmack-Lahane 1, Malampatti 2, Carmack-Lahane 2, Malampatti 3, Carmack-Lahane 3 and 4, like that. So that is what they interpreted initially. So what is this Carmack-Lahane scoring?
This
visualization of
glottis.
Okay. What is Carmack-Lahane 1?
1 is full view of the glottis, sir.
Okay.
2 is classified 2A, 2B, sir. 2A is partial view of glottis. 2B is posterior commission arytenoids are seen.
Okay.
3 is classified 3A, 3B, sir. 3 is both in epiglottis seen. In A is epiglottis is liftable. B epiglottis not liftable, sir.
Yeah, fixed epiglottis. Okay.
4 is posterior part of tongue.
Base of the tongue.
Yeah, you don't see any part of the larynx. That is Carmack-Lahane. This initially Carmack-Lahane classification was 1, 2, 3, 4. There was not 2A, 2B or 3A, 3B. Who classified this? Who modified it? Modified by Cook. Cook's modification of Carmack-Lahane scoring. One more laryngoscopic scoring is there. What is the other? Pogo scoring. That also you should be knowing. What is this Pogo?
The percentage of glottic openings.
The percentage of glottic opening. Okay. So that is about the Malampatti. And now you know that Malampatti alone may not be a highly sensitive or predictive for difficult airway, isn't it? Many times you must have had Malampatti class 3 or class 4. When you do a laryngoscopy, you will be able to see the Carmack-Lahane one. So that is why, a single test does not imply whether it is a difficult airway or an easy airway. You have to go for multiple airway tests to assess the airway. So the other important thing you have written is about the thyromental distance and thyromental distance. So what is this thyromental distance? How do you measure it?
So normally we measure with the head full extension from the thyroid cartilage to the chins. So thyroid mentum to the chins.
Mentum
to the tip of thyroid cartilage.
Upper border of the thyroid cartilage?
Upper.
Upper border of the thyroid cartilage. So what should be the normal?
Normal should be more than 6.5 centimeters.
Okay. So what is this thyromental distance? actually, what is the significance of this?
Just like submandibular space, sir.
So that we'll be able to lateralize the tongue during scoping, sir.
Yeah, so that, you can push the tongue in the space, which is called as the mandibular space. This mandibular space, you can say from angle of the mandible to the thyroid cartilage and to the mentum. So this triangle, isn't it? Or sometimes in the older times, the triangle was hyoid bone, mentum, and the angle of the mandible. This was they called as the mandibular space or the triangle. So who actually introduced this triangle of mandibular space?
Patel.
Not Patel, Patil. Patil, a Maharashtrian, Patil. She's a lady, not a male anesthesiologist. Lady anesthesiologist from Maharashtra, of course, settled in US. Patil's contributions are many. Of course, in Lemon also you have the
332.
Yeah, 332 again, Patil. So we'll come to that again. So that is thyromental distance and hyomental distance, again, very important. What we have found is this thyromental distance is the most important thing when even compared to the Mallampati scoring. If the thyromental distance is good, more than 6 centimeters or 6.5 centimeters, the laryngoscopy invariably will be quite easy. It is not a difficult thing. And why thyromental distance other than the mandibular space? Mandibular space is hyomental and angle of the mandible. This is why thyroid cartilage is included here. The distance between the thyroid to the mentum, not tricard to the mentum. Why? What is the significance?
Because it's anterior lies.
Now, thyroid cartilage is important as far as the larynx is concerned. What is its importance?
Moves.
No, vocal cords are attached to which
Thyroid.
anteriorly. Anteriorly, it is the thyroid cartilage, isn't it? So that is how, you have to see the glottic opening. So you'll have to see the vocal cords. Since the vocal cords are attached anteriorly to the thyroid cartilage, so this thyromental distance becomes very important. If this distance is short, as you are talking about, so what will happen is, one is that the vocal cords will be more anteriorly placed. So your direct laryngoscopy will not be able to visualize, because it is more cephaloid placed or anteriorly placed. So that's how thyromental distance becomes very, very important. So that is about thyromental distance. Another is the sternomental distance. So again, what is this sternomental distance?
So it is also measured with from the upper border of sternum to the mentum. So with full extension.
It is actually from the suprasternal nerve to the mentum with the patient's head completely
Full extension.
extended. Okay, so again, what is its importance?
So it also defines the difficult laryngoscopy intubation.
No, why? What it indicates actually, it is most often is used in obese patients and pregnant patients. Sternomental distance. It is mainly it indicates what is the length of the neck. Whether it is a short neck or it's adequate length is there. So because length of the neck is again very important, because if the length of the neck is short, again, the larynx will be more anteriorly placed and you will not be able to visualize the larynx with direct laryngoscopy. You may have to use a video laryngoscope, and that too an hyperangulated video laryngoscope. So that is the idea. That's why, many times with obese patients or obese pregnant patients, we directly go for a video laryngoscope, isn't it? So because their neck is short, because their sternomental distance is short. Now, another one which you have written is upper lip bite test. So how do you do this upper lip bite test?
So the lower, it is divided into 3 classes, class 1, class 2, class 3.
No, how it is done actually? What you
are asking the patient to protrude the mandible above the maxilla, sir, so that he'll be able to.
You should be upper lip bite.
Lower incisor to above the.
Yeah, so he is supposed to bite the upper lip by his lower incisors. You just ask him to bite the upper lip with the lower incisors, and you see whether he is able to completely bite the upper lip. That means upper lip is not seen at all. Above the margin of the upper lip, if he is able to cover with this lower incisors, it is grade 1. Okay, grade 2 is
at the level of
yeah, it is still upper part of the lip is seen. Third is
Not
Below.
able to.
Not able. He cannot protrude the mandible at all. So this is what is called as upper lip bite test. Who introduced this?
Calder.
Calder.
Huh? No.
Mandibular protrusion.
It is Z.H. Khan, Zakir Hussain Khan from Iran. So it was actually introduced very recently in 2005. Actually, he introduced this upper lip bite test and it has become quite popular. So what does it give you an idea, upper lip bite test?
TMJ.
One is the mobility of the TMA joint and another thing is maxillar protrusion. Suppose the maxilla is too much protruded, again the patient will not be, even though his mobility of the mandible is good, he'll not be able to bite. Suppose overbiting incisors are there because of the maxillar protrusion. Then also there are two things you can make out. One is the mobility of the temporomandibular joint and again the maxillar protrusion. So that is upper lip bite test. And one more this thing is regarding which of course in this patient he will not be able to do it, is neck mobility. Extension of the neck and flexion of the neck, isn't it? So from neutral to extension, how much should be the normal angle?
More than 80 to 85.
From neutral to extension. I'm not asking from complete flexion to extension.
36, more than 30.
Yeah, more than 35 degrees. So usually you check for neutral to extension. So how do you check for neutral to extension? How much is there? And roughly?
We have to keep the patient head in neutral positions and measure the upper alveolus, and we have to ask the patient to extend the head, and that angle we have to measure.
Okay, so that is one of the methods. Or otherwise, without moving his eyes, with only moving his neck, you ask him to look at the ceiling of the room. So if he's able to look at the ceiling of the room without moving his eyeballs, so that means his airway his cervical mobility is good. So these are some of the important things as far as assessments are concerned. And when you're talking about the difficult airway, there are so many difficulties as far as the airway is concerned, isn't it? One is difficulty as far the mask ventilation is concerned. Second thing is difficulty in laryngoscopy and intubation. Third thing is difficulty as far as supraglottic airway device is there. And fourth is difficulty for
surgical access.
Yeah, surgical air, front of the neck access. So can you define each one of them?
So difficulty in mask ventilation, we can do like bearded individual, obese.
No, what is this? So when do you say difficulty in mask ventilation?
So the conventionally trained anesthesiologist now, unassisted anesthesiologist is not able to maintain a patient saturation of more than 90% with 100% FiO2 and positive pressure ventilation. And there is with two hands. With two hands, yes.
With two hands, with the patient saturation
was more than
90.
of saturation was more than 90% before the intervention of anesthesia.
So that is what is the difficult mask ventilation is concerned. Okay, what is difficulty in the laryngoscopy and intubation? What is difficulty in laryngoscopy?
Could not be any part of the glottis.
Again, you have to say conventionally
trained.
Using a conventional laryngoscope, not able to visualize any part of the larynx, like Carmack-Lahane grade 4. That you call it as the difficult laryngoscopy. Okay, difficult intubation.
So when we convince train, like couldn't intubate within 3 times, or takes more than 10 minutes.
Yes, if he is not able to intubate with more than 2 attempts or taking 10 minutes, you call it as difficulty in intubation. So difficult introduction of the supraglottic airway device. When do you say you have a difficulty as far as introducing a supraglottic airway device is concerned?
Restricted mouth.
Not able to position a supraglottic airway device properly even after 2 attempts. That you call it as a difficult introduction of supraglottic airway device. Okay, what about difficulty in front of the neck axis? When you cannot see any of the anatomy properly of the front of the neck, wherein you will not be able to access the airway, that you call it as a difficult front of the neck access. So each one the factors which can decide, each one you have, mnemonics are there. Okay, for mask ventilation, what is the mnemonic?
Bones are
Bones or moans.
Yeah, bones, okay, or moans. What is this bones?
B for bearded individuals, sir. O for obese. N for no teeth. E for elderly. S for snorers.
No, BONES, isn't it?
Yes, sir. N for no teeth. E
No.
elderly. And S for
Elderly more
snorers.
than 55 years of age.
N
BMI
for
more
no
than
teeth,
26.
edentulous.
Elderly.
N is no teeth, isn't it?
Yes, sir.
So that is bones. Okay. That is for difficult mask ventilation. Especially, they have found out that the patients with the beard, huge beard, they are one of the most difficult. Of course, both of you are sporting beard, but it will not produce any much of difficult. You must have seen there are patients wherein you cannot see the mouth, big mustaches, and then huge beard and religious this thing. They would continue to sport that, and you'll not be able to shave off the beard and then the mustache, isn't it? In such individuals, sometimes you may not be able to see where is the mouth. You may have to give them something to drink, then you know where is the mouth. So the whole lower part of their face will be covered with hair. So very difficult airway. One of the most difficult mask ventilation will be with bearded individuals. So that is about the difficult mask ventilation. Okay, what about difficulty in introducing a supraglottic airway device? What is the
Rods.
RODS, RODS. What is this RODS?
Restricted mouth opening, sir.
Okay.
Obstruction of the upper airway and
Not
distortion
obstruction of the upper airway, actually. It is obstruction beyond the larynx. Obstruction, suppose if there is an obstruction beyond the larynx, so you'll not be able to ventilate, isn't it? With a supraglottic airway device. So restricted mouth opening is very important, that because you cannot introduce the obstruction beyond the larynx. And D is
distortion in the anatomy of the
distorted anatomy of the pharynx. This can be, as you said, that
upper
upper airway, distortion of the anatomy of the pharynx. And S is
stiff lungs.
Stiff lungs. Again, stiff lungs, why it's important for a supraglottic airway device?
Airway pressure will be more.
Compliance will be reduced, sir. So increased pressures will be required to
ventilate. Isn't? So airway pressures will be much higher than whatever the pharyngeal seal pressures. There will be a lot of leak. So that is about rods. Okay. As far as difficulty in laryngoscopy and intubation,
we have the Lemon criteria.
Lemon criteria. What is this LEMON?
So look externally.
Okay.
Evaluate, that is 3:3:2, and M for the Mallampati, O for obesity, and N for the obstruction and obstruction obesity, and N for the neck mobility.
Neck mobility, isn't it? So in that you have written about this Patil's 332. Second one, of course, look externally, it is always there, because many times from externally means it is from front and also from the sides you'll have to look for. And any trauma or any abnormal faces, so immediately you will come to know, isn't it? So what is the 332?
Sir, 3-finger breath, mouth interstitial gap, mouth opening for more less than 3 centimeter, 3-finger breath, and
Okay.
the thyromental distance is less than 2-finger breath, and the
Not the thyromental, it is
thyromental.
Hyomental.
No, hyomental is 3.
3 fingers is again mouth opening. Another 3 is hyomental.
Hyomental, and 2 is thyromental.
Oh, floor of the mouth to
Thyroids.
Actually, Patil's 332 was 2 fingers between cricoid cartilage and thyroid cartilage. 2 fingers between thyroid. If you say, under surface of the mouth, 2 fingers, it doesn't carry any meaning, isn't it? So because already you have measured hyomental distance here, 3 fingers, and 3 fingers oral, interincisor gap, and 2 fingers in the distance between the cricoid cartilage and the thyroid cartilage, lower part of thyroid and upper part of the cricoid cartilage. That is Patil's 332. So that Lemon scoring is also many times we'll be using for if the lemon scoring is high. Naturally, in this patient, you have written as lemon scoring as 7/10. So what is this 7/10? How do you score lemon? How many points for L?
4, sir.
For what are these? How do you score?
Most like bearded, sir.
One is beard, okay.
And length of upper incisors.
Large incisors.
And large tongues.
Okay, large tongue.
Facial edema, like traumas.
Yeah, facial trauma. So 1, 2, 3, 4. So that's how you give. And for evaluate 3, 3, 2, again,
Each
Each
carries
1 point.
yeah, so 4 plus 3 plus other 3 is each one score. So total 10. So anything more than 5, we can always consider it as a difficult airway. So that is difficulty in laryngoscopy and intubation. That is about lemon score. So then you have difficulty as far as surgical airway. So what is the mnemonic?
bangs.
Bang or short is
Short.
usually we use to SHORT.
Uh,
S stands for any surgeries that has been done in front of the neck. H is hematoma
Hematoma.
in front of the neck, large hematoma if it is there. And O is
Obesity.
obesity. R is
Radiation.
Radiation.
patient has had exposed to radiation, contractures will be there. And T is tumor.
Tumor.
Any tumor like thyroid
Thyroid.
or any other cystic hygroma, huge cystic hygroma. So these are the difficulty in surgical airway. Okay, now we'll discuss about this particular patient, how you are going to get the airway. Your patient, like a patient with a neck contracture. Also, we'll discuss about the management of other difficult airways. Okay, now this particular patient yours who has got a neck contracture. So how do you provide anesthesia for him for release of the neck contracture?
The first plan of choice will be awake fiber optic nasal intubation.
Nasal or oral intubation.
Okay, awake fiber optic intubation, that is the best, because you've already also seen the patency of the nostrils, because you may have to go with nasal also, or you can even go for oral also. Which one is easier?
Nasals.
Why nasal fiber optic is slightly easier when compared to oral?
So
because
mouth opening sometimes will be restricted.
No. Here mouth opening is good.
Natural pathway will be.
So naturally, the nasal cavity and nasopharynx will lead to what? Will lead to larynx. It is always. And oral cavity will lead to what? Esophagus, because we eat and we breathe through our nose. So that's how it becomes easy for us to go through the get into the airway with a fiber optic scope through nostrils. It becomes nasotracheal becomes easy. Anyway, in this patient, either you can go for orotracheal or nasotracheal, doesn't matter. But because his mouth opening is also adequate for fiber optic scope, so that is one of the methods you can definitely use. But how many times you have done a fiber optic intubation?
Observed twice, sir.
Twice. Is it easy or it's difficult?
Observed twice.
Observed. That's all. Not done. So invariably you will be asked the same question in the exam. So how many times you have done? Because you have to be, unless you are good in that particular method of getting the airway, so you should not attempt it, isn't it? Suppose, let us say that you observed, briefly you tell how you do it. Then we will go for the other methods. Suppose you do not have a fiber optic scope, or you don't know how to use a fiber optic scope.
Starts with the nasal preparation first.
Counsel the patient.
Go for awake or
Awake.
Yes, awake.
Yes, sir.
So because this is an anticipated
Difficult
airway, isn't it? Whenever you have airway guidelines are there and airway algorithms are there, and you have American Society of Difficult Airway Society guidelines are there, ASA, and usually the latest one is in 2022, American Society of Anesthesiologists. difficult airway guidelines, and you have DAS guidelines are also there. That is European guidelines, Difficult Airway Society guidelines, and IDA guidelines, our own All India Difficult Airway Society guidelines are there. So, and DAS almost in 2016, not updated now. And ASA is the latest one, 2022. And all these have one common thing first. So whether it's an anticipated difficult airway or unanticipated difficult, isn't it? So majority of the times when you do all these tests, you can definitely 30% or 40% of the airways you can anticipate. And especially in a Burns contracture, it is an anticipated difficult airway. So once you know that it is an anticipated difficult airway, first thing, what question you will ask yourself? That is there in the algorithm. That's why I'm asking. Difficult airway.
Awake or
Chief anesthetist.
No. Should you, intubate and induce, or should
Awake
you
or
induce and intubate? That is the first question, isn't it? Because is it possible for you to intubate after GA or after anesthesia, or you have to get the airway first because it is so difficult? Probably you may not be able to get the airway once you. That is the first question you should ask yourself, and then decide whether to go for awake intubation or intubation after induction, isn't it? So in this patient, if you ask this question, what you should, your answer will be?
Awake fibrillation.
I'll go with awake intubation.
Yeah, probably you may go in awake. So again in awake, once you think about awake intubation, again the question you have to ask yourself is, what is the question? So you should know about this algorithm very well. That is why I was just asking about. Once you think that
With
you have to,
with sedation or
no. Awake intubation, you have to give sedation, or sometimes you don't give sedation. That is not the most important thing. Again, you will have to think about whether you go for natural airway intubation or you go for surgical airway. Because sometimes, for example, now there is an obstruction inside the mouth, the tumor inside the mouth, or there is so much of infection, submandibular abscess, the huge abscess is there. Such situation, you may have to go for a surgical airway straight. Isn't it? You know that definitely if you try even awake intubation, you will not be able to see anything inside. Even fiber optic or video laryngoscopes will not see anything inside. So much of edema will be there inside, or a huge tumor inside, you'll not be able to see anything. So that is what, when you think about awake intubation, again, conventional method of intubation, or you go for surgical airway. And the other thing is, you think that you can induce and then intubate the patient. In that, again, what the question you have to ask?
Airway patency will be maintained.
Airway patency to be maintained means what? What?
Spontaneous ventilation.
Yeah, should you paralyze the patient or you should not paralyze them? So that is what the basic thing as far as the algorithm is concerned. So that is what you'll have to think about. In this patient, definitely surgical airway is ruled out, because in this patient, there is a question of surgical airway. So much of contracture is there. Front of the neck access is not there at all. So if you happen to go for induction and then try to induce, and if you happen to go into a situation where cannot intubate, cannot oxygenate, then there is no option for you to go for a surgical airway in this patient. That is why ideal to go for will be awake intubation only. So that is what is very important. So how do you go for awake intubation in any patient for that matter?
So first we have to counsel the patient regarding this.
Yes, very good.
Liquid counseling and consent and psychological preparation of the patient.
Why should you counsel the patient?
Patient's cooperation is important in this, like doing the procedure. You have to obey the
most important thing, isn't it? The patient's cooperation is the most important. Okay. So you are counseling the patient, right? Then? And
we have to nebulize the upper airway.
Decongestion.
So you have to anesthetize the upper airway. So what are the methods of anesthetizing the upper airway?
So we can
what are the nerves that are, first you tell about the nerve supply of the upper airway, and then you know how to anesthetize.
So for nasal, we have to add greater palatine nerves, ethmoidal nerve.
Is it only the greater palatine? It is
Right
actually,
lesser palatine.
what are the anterior aspect of the inner part of the nose and posterior aspect of the inner part of the nose?
Sphenopalatine.
Lower part of the inner part of the nose. So anteriorly it is by anterior ethmoidal nerve. And posteriorly the roof is by the posterior ethmoidal nerve. And the floor is by nasopalatine nerves. So these are the branches of what nerves basically. Ethmoidal nerves are branches from which nerve? Ethmoidal are branches of ophthalmic division. Okay, then the palatine nerves from the sphenopalatine ganglia, that is from the maxillary division. So the maxillary division and the ophthalmic division, they supply the nose, inner part of the nose, which you have to anesthetize. Okay, so then oral cavity.
Loss of pharyngeal.
The anterior 2/3 and posterior 1/3. And 2/3 of the oral cavity by oral cavity, anterior 2/3. Anterior 2/3 is by lingual nerve, which is a branch of mandibular division. The posterior 1/3, glossopharyngeal. So very good. So then you have the superior part of the larynx and inferior part of the larynx. The superior part of the larynx, that is
internal branch of superior laryngeal.
Internal branch of the superior laryngeal, which is a branch of vagus. Again, the inferior part of the larynx, recurrent laryngeal. Again, branch of
external.
No.
Vagus.
Again, vagus nerve. Vagus nerve supplies the superior part of the larynx and inferior part of the larynx. So through internal branch of the superior laryngeal and recurrent laryngeal nerves. So these are the nerves which you have to block, isn't it, for awake intubation. So what are the different methods of blocking these nerves?
So first we can nebulize the 4% top.
One individually you can block. Individual nerves you can block. That produces very effective analgesia, especially particularly if you are going in for awake orotracheal intubation using your Macintosh blade or your video laryngoscope, because you will be using slightly more pressure and also you will be stimulating gag reflex, isn't it? So that if that thing you are doing, then it is better to individually block each nerve and then proceed. But if you're going for a flexible fiber optic intubation, even as you said, nebulization with 4% lidocaine should be ideal. Nowadays, they are even using dexmedetomidine after nebulization. And also they are using, remifentanil is becoming very popular for intubation, awake intubation. After nebulization, they start, remifentanil, continuous infusion with first loading dose. And they give very high dose of remifentanil. What is the dose of remifentanil that is used for awake intubation?
0.15 mics.
It is
0.5 mics.
0.15.
No, for awake intubation, it is 1 to 3 micrograms per kg body. It is a high dose. 1 to 3 micrograms per kg body weight. Now it is becoming very popular as far as the awake intubation using remifentanil. Okay, now how do you block each of these nerves?
So for nasal, we can pack with the 1% lignoadine and pack the nasal package.
Only lidocaine or with adrenaline?
With adrenaline.
Why with adrenaline is better?
Bleeding, to reduce bleeding.
Vasoconstriction, so that the passing will be atraumatic.
Nasal decongestant. You can use any of the nasal decongestant also, isn't it? You can even use some thilometazolin drops, nazivian drops, definitely. And afterwards, along with that, lidocaine with adrenaline. Because another thing is absorption also will be less, because you'll have to calculate the total dose of lidocaine you will be using finally. So that is what you are asked many times, this particular question, and one examiner will be noting down how much of lidocaine you are using. So total dose, because you should not exceed the safe dose of lidocaine, isn't it? So that is with adrenaline, the absorption is much less. We know that with adrenaline, you can use higher doses of lidocaine also, isn't it? Okay, so lidocaine with adrenaline that you pack, at least for about 10-15 minutes, then you can take out the packs. So that is for nasal anesthesia. Any other particular local anesthetic is ideal for nasal anesthesia?
Cocaine we can use.
Yeah, cocaine was most commonly used. Even in US now also they use cocaine locally, and they pack the nasal cavity with cocaine. So either 4% cocaine or 10%. Why cocaine is very popular for nasal?
So it inhibits like noradrenaline inhibit, so more vasoconstricts.
Now, why it produces vasoconstriction?
Inhibit the noradrenaline.
It reuptake of noradrenaline and the nerve endings, autonomic nerve endings. So it prevents the reuptake. The amine pump it inhibits, so that more availability of norepinephrine at the junction between the autonomic nerve ending and the smooth muscle. So that can produce vasoconstriction locally. So that's how cocaine is quite popular in US even now. Okay, so that is about the nasal anesthesia. So how are you going to block the lingual nerve?
So lingual we can block by two types, either by giving direct incision of the premolars, second lower premolar.
Okay.
Or viscous lignocaine we can use.
Usually, majority of the times, you make the patient to gargle the lidocaine viscous. What is the percentage of lidocaine?
2%.
2%. You have used?
Yes.
You have used. Okay, so that's good. Now about glossopharyngeal.
So we can use the spinal, long needle and give you posterior tonsillar pillars.
Yeah, base of the posterior tonsillar or anterior tonsillar. Anyway, at the base of the tonsillar fossa, if you just use 1 ml of 1% lidocaine with adrenaline is enough. On either side, you can definitely raise a wheel there that will block. So that is internal approach. What is the external approach for glossopharyngeal?
Between the styloid, mastoid and styloid process.
No. Between the posterior, that is, the angle of the mandible and the tip of the mastoid, exactly in the midpoint. So you go perpendicularly, now you will be hitting the styloid process. Now you walk anteriorly and just beyond the styloid process, because just behind the styloid process, you have the glossopharyngeal. That's how, for example, a patient mouth opening is not there. In that, internal approach will not be possible. Then you'll have to go for an external approach. Okay, so that is about the glossopharyngeal. Again, internal branch of the superior laryngeal, how do you block?
Internal, like first we have to palpate the hyoid bones. And,
okay.
And the which side you are first we have to lateralize the hyoid bone, and you have to greater corner of hyoid bone should be hit the first with the 22 needle. We have to hit it, sir, and go inferior. And you
have to block it in between the greater cornu of the hyoid and the greater horn of the thyroid cartilage. So you palpate the hyoid bone, just come down and then move your finger laterally. Your finger will dip into this fossa, wherein between the cornu of thyroid and greater horn of hyoid. So there is, in that fossa only, you'll have to inject, isn't it? So ideally, you can hit the greater cornu and then walk down and then introduce, not more than 2 to 3 millimeters deep. So you will have to aspirate. You should not aspirate for what? Air or blood. If you aspirate air, where is the tip of the needle?
Trachea.
No, trachea is much lower. Because you are actually piercing what? Thyroid membrane you are piercing, isn't it? Because the internal branch will pierce the thyroid membrane and it will be supplying the piriform fossa and also over the superior surface of the area of the vocal cords. So that means when you aspirate air, your needle has pierced the piriform fossa mucous membrane and it is in the oropharynx or the nasopharynx. So if you aspirate blood, it is inside a blood vessel. So that is why you should not get blood or air when you aspirate before injecting. So you can inject 1.5 ml of lidocaine with adrenaline, 1%. On either side, you'll have to do. What is the internal approach of blocking the internal branch of the superior laryngeal nerve? So you'll have to place, gadgets of wool dipped in local anesthetic, and you have to use cross forceps. Cross forceps is right-angled forceps, and you have to keep it inside the piriform fossa on either side for about 2 to 3 minutes. That is the internal approach. So you may have to use your laryngoscope a little bit and then visualize the piriform fossa and then place the gadgets or, the pledgets, not gadgets, sorry, pledgets of wool or even gauze dipped in local anesthetic. That is the internal approach. Okay, so now coming to the recurrent laryngeal nerve area block. It is not, you are not going to block the recurrent laryngeal nerve. You are going to block the recurrent laryngeal nerve area supplied by the recurrent laryngeal nerve. So that is what is called as the translaryngeal block or transtracheal block sometimes. So how do you do this?
We have to palpate the cricothyroid membrane and go perpendicular with aspirating, sir. Once we see the air bubbles, we have to ask like 2 to 3 ml lignocaine.
Which lidocaine, which preparation?
4% lignocaine, sir.
4% lidocaine. Okay. So when do you inject?
Like inspiration.
Asking the patient to cough. So
No.
inspire.
If he coughs, your needle will break. That you should avoid actually. So when do you which part of the respiration you will be injecting?
Inspiration.
At the end of inspiration, you have to inject. Ask the patient to take a deep breath. And when he takes a deep breath, at the end of inspiration, you rapidly inject and come out. So then the next phase will be expiration, and otherwise he coughs because it's a foreign body. So next phase is expiration because you want the drug to come up and then, block the area just underneath the vocal cords. Otherwise, because of gravity, everything will go down. So that is why at the end of inspiration, if you just inject, so next phase is expiration. So some part of the drug will come up also. And that is the idea of when to inject. So what are the complications of this particular block? One I just mentioned, broken needle. Needle can break inside and then it becomes a big thing. You'll have to get an ENT specialist to take out the needle, do a rigid laryngoscopy. And what are the other things? There can be hematoma formation. You may go through a blood vessel. Thyroid ema artery is there in that. So that is one problem, hematoma formation. Third is you can produce surgical emphysema. So your needle goes through and through and then pierces the esophagus there. So air starts entering and then you can produce surgical emphysema. And the fourth is infection if you're not taking care. So these 4 complications, invariably you will be asked about translaryngeal block. So you should know about it. So this is how you block individual nerves. And in a patient with full stomach, this is another question you will have to ask yourself. Is the patient full stomach when you're planning for a difficult airway management? Because if the patient is full stomach, there is no question of going for induction and intubation. You have to go for intubate first, get the airway, and then induce the patient because the risk of aspiration will be very high. So how do you, which particular thing you will omit nerve blocks in a patient with full stomach? You will not block the superior laryngeal nerve. That is the internal branch of the superior laryngeal nerve. Because that is the one which actually protects the airway. As soon as a foreign body touches the superior surface of the larynx, the whole glottis will close, isn't it? So that is why you just omit that particular block, and then you do a laryngoscopy, spray the vocal cords, keep your laryngoscope there only, and then wait for 1 or 2 minutes, and then you intubate. So this is another very important thing in patients with full stomach. You don't anesthetize the superior laryngeal, that is the internal branch of the superior laryngeal nerve. Okay, so these are the nerves you have to block. But in your patient, who has got, contracture of the neck. So you may not be able to block many of these nerves. Nose, no problem. You can definitely use packing of using lidocaine with adrenaline. And other nerves may be very difficult. Of course, his mouth opening is good, so you can still block the glossopharyngeal and you can block the lingual. But the vagus nerve branches, superior laryngeal and recurrent laryngeal nerve, you will not be able to block. So you go for additionally nebulization, you said. It is okay. Or spray as you go is another SAGO technique. When you're using fiber optic scope, you can also go for a SAGO technique. Okay. So that is how, the fiber optic, how you, now how you position the patient, how do you go ahead with the fiber optic scope?
So the patient will be asked to be in the sitting position and the operator will be standing in the front, sir. So
No,
he'll be able to
sitting, he can lie down also.
lie down.
No, nasotracheal. Usually, majority of the times we do in the lying down posture only. Patient is comfortable. Only thing is, if he is possible, it is possible to extend his head and neck and sniffing position. It will be better. But now it will not be possible. So you go with, patient flexed only. So you have done always in the sitting posture, is it? In what you have seen?
No, sir. I actually read it from the recent intervention.
You can definitely lying down posture. The patient will be comfortable. You will also be comfortable. So sitting is only when you want to go for orotracheal. Then definitely sitting may be one of the methods used. Even then, lying down you can definitely use. Orotracheal, any special airways are available for fiber optic intubation? Any special airways? Have you heard about Barman's airway?
Barman's airway.
Barman airway is one wherein, on either side it is open. It is only a bridge is there in the middle. So through one opening, you are introducing your fiber optic scope. With the other thing, you can do suction and also you can give oxygen. So that is a Barman airway. One more airway. These are kept in the exam also. Ovosapien airway. Ovosapien airway, when you introduce it, and through that, once you introduce the fiber optic scope, your scope is directed towards the larynx easily. So it becomes orotracheal intubation will be very easy with the ovosapien airway. Otherwise, is a Patil's airway. Patil's mask actually it is. And wherein, with the mask only, you can continue to oxygenate the patient. And there is an opening, self-closing opening in the mask. So that through that opening in the mask, you can introduce the fiber optic scope and then intubate the patient. So there are different gadgets definitely you can use. Okay, so let us say that, how do you go ahead now? You have decided about this, okay, in sitting or lying down, right?
We'll nebulize, sir, and we'll give antiemetic and anti-sialox, sir.
Antiemetic also, na? Okay. Anti-sialagogue is usually,
like
before you nebulize, you give anti-sialagogue. And you want to get an IV line or not?
Yes, sir. We'll be securing a wide IV Canada either in the pre-op or
you have to give some slight sedation also. You can definitely use sedatives like dexmedetomidine or remifentanil or even fentanyl, midazolam. So these are very important for making the patient to be more cooperative. Isn't it? He can cooperate better. Okay, then
we'll attach the monitors and check the nasal patency, which will be better.
Okay, okay.
And while inserting, we'll go through spray as we go techniques.
No, but how are you going to intubate? You have to, thread the endotracheal tube over the fiber optic scope, isn't it? First,
yes.
That is very important. You have to fiber optic over the fiber optic scope. First, you have to thread the endotracheal tube, and then you go, through the nasal cavity if you are planning for, or through the oral cavity, whatever you are planning for. And what you should be seeing when you are going through the. No, you should always looking for the openings, that is, darker area. So that, the dark area is the openings continuously. So that's how you first see the epiglottis. Underneath the epiglottis, you can introduce this thing. And then afterwards, what you should, your target is what?
Carina.
The carina is your target. Okay. Once you see the carina, you can just push the endotracheal tube. So that's how fiber optic scopy you can do. Okay. Now let us say that in this patient, you wanted to do a fiber optic scope, either it's not available or not works with that. So what other methods you can adopt?
Awake video laryngoscope.
Awake video laryngoscope, definitely you can try. Okay. So which particular video laryngoscope you use?
So here we use CMAC.
CMAC, the regular blade, you will not be able to see
D
anything.
blade. D blade.
So you may require to go for a D blade, hyperangulated D blade. Okay, so that is one of the things you can definitely use. Okay, any other method you can use? Suppose you don't have D blade video laryngoscope.
Ketamine is contracture.
Pardon?
Blades.
No. You don't have video laryngoscope.
That was IV induction contracture. Ketamine is contracture or inhalational contracture.
No. Can you use any other gadget for intubation?
Supraglottic airway device.
You can use an ILM.
Inhalational inductions.
No, ILM you can use. Even awake, after anesthetizing, because oral cavity you can anesthetize. Glasopharyngeal nerve you can anesthetize in this patient. So once you anesthetize, you can, with the cooperation of the patient, you can introduce an ILMA. And once you, make sure that the patient is able to ventilate well, you can even introduce your fiber optic scope through the ILMA and then intubate the patient. That is one of the things. Or any LMA with a camera there. What is that LMA? ILMA is called as fast track LMA. And ILMA with a camera, which they have stopped manufacturing. And that is also called as a video laryngoscope nowadays. It is called a C-track LMA. C-track. So it will have a camera in the aperture. So continuously you can see whether it is, your tube is, ILMA is a blind intubation, isn't it? Whereas a C-track LMA, your endotracheal tube is passing through the glottic opening. Under vision, you are intubating through the C-track LMA. So that is another thing which you can definitely introduce from the front, this ILMA, because the ILMA has got a fixed curvature is there, isn't it? So the airway tube has got a pharyngeal curvature which you can introduce it, and through that you can intubate. Or suppose you are not able to intubate, you can, if you are able to ventilate the patient, and if it is a proper fit, you can even provide general anesthesia to open the contracture. So that is one of the techniques you can always tell in the exam. Okay, then you were talking about the ketamine.
Ketamine.
Yeah, ketamine is another very important thing. Definitely you can use ketamine till they, take out the contracture, they release the contracture. Once the contracture is released, you can do your regular scopy and then intubate. Okay, so one more technique is tumescent anesthesia. Many of the plastic surgeons nowadays, they are using this tumescent anesthesia for opening the contracture or releasing the contracture. So how this tumescent anesthesia, you prepare the local anesthetic for tumescent anesthesia.
Klein solution is Klein tumescent is that.
Pardon?
Klein, sir. Like 1000 ml of normal saline.
Okay.
And 1 milligram of adrenaline, sir.
Okay, 1 in 1,000 or 1 in 10,000?
1 in 1,000.
1 in 1,000.
1 in 1,000. Okay.
Then 1% lignocaine 50 ml, sir.
1%, 50 ml or 2%?
25 ml.
Because you have 2% lidocaine. So basically you have to take 500 milligrams of lidocaine. And 0.05% of lidocaine you have to prepare with adrenaline, isn't it? So what is the maximum?
Hyaluronidase, 1,500.
Hyaluronidase also you can add. And sodium bicarb. How much sodium bicarb?
So 12.5 ml. 8.3%.
2.4%, 12.5%.
12.5 milliequivalents. And 8.4 sodium bicarb, each ml is 1 milliequivalent. So what is the advantage of tumescent anesthesia?
So the bleeding will be reduced.
One is hardly any bleeding, okay.
So the tissue gets swollen so that for the contracture release will be easy. And the,
Easy. Prolonged anesthesia will be there also, 18 to 24 hours of anesthesia. And
local anesthetic systemic toxicity also is less because of dilution of the anesthetics.
no, because of actually, adrenaline you are using, absorption will not be there. And second thing is, when you, inject so much of the anesthetic there, local anesthetic, the tissues are separated and the vessels are under pressure. That is how, it becomes so firm. The whole thing becomes so firm subcutaneously. And because of that pressure, all the vessels are, constricted. So there is hardly any bleeding or any absorption because the vessels are constricted. That is why what is the maximum amount of lidocaine one can use?
35 mg. It's totally 35 mg per kg.
35 to 50 milligram per kg body. 35 to 50 milligram per kg body weight can be used because the absorption is so less. And maximum concentration, blood concentration they have found is just, about 1 microgram per ml. Because we know that anything above 5 microgram is a toxic concentration. Here it is just about 1 microgram per ml is the concentration that is achieved because the absorption is so low. So tumescent anesthesia is one of the other things you can always use. Okay, so this is what you can use in this particular patient and manage for neck contracture release. So let us say that another patient is there who has got a difficult airway. He doesn't have a neck contracture, but when you have examined and multiple tests have been found to have a very difficult airway in a particular patient. And in that patient, again, the mouth opening is restricted. Let us say he's got a temporomandibular joint ankylosis. So what are your different options of getting the air? There is no neck contracture.
You can use airway blocks and those.
Mouth opening is restricted.
Nasal, like awake nasal intubation, sir.
One is awake, fiber optic intubation. As you said, that will be the first thing. And suppose, I told you that you are not good in fiber optic or you don't have. What are the next option? Now, these are the things you will be asked in the exam. That's why I am asking.
Plain? Yes.
What is the second option? Second option will be blind nasal. Blind nasotracheal intubation. So because, in the probably 1920s and 1910s, when laryngoscope had not been introduced, because the Macintosh laryngoscope was introduced in 1927. Till then, they did not have laryngoscopes. So they were going in for blind nasal intubation. It was very popular, blind nasotracheal intubation. Magill and Waters, they were very good in blind nasal intubations during those days. Under ether anesthesia, they used to just, within seconds, they used to get the airway. So that is blind nasal intubation. Awake, you can definitely use, or awake or under anesthesia. Inhalation anesthesia, you can definitely go for. What is the third option?
Retrograde.
Retrograde wire intubation. Retrograde wire intubation, isn't it? That is the third option. What is the fourth option?
Yes.
Tracheostomy, isn't it? So because you will be asked about these options, and then in the exam we will be asking you any particular one of them. We may ask you, okay, how are you going to do a fiber optic? How are you going to do an awake blind nasal intubation, retrograde wire intubation, or sometimes for tracheostomy? So any of these questions can be asked. Okay, have you done any time blind nasal intubation, awake or under?
Awake, yeah.
Blind.
Blind nasal.
Blind nasal.
Not see, isn't it? But you should know about blind nasal intubation because many times if there is a blood in the pharynx, your fiber optic scope will be useless. If there is a blood there, you cannot see anything. So then, and the patient has got a restricted mouth opening, then you may have to go for either blind nasal or retrograde wire intubation. So let us just talk about retrograde wire intubation, and if time is permitted, blind nasal also. So this is one technique. It is said that every anesthetist should know retrograde wire intubation, especially in those patients where they have a trauma or they have blood in the oral cavity and continuous bleeding is there, and your fiber optic will not help in such situations. And in such situation, ideal would be to go for a retrograde wire intubation. So how do you perform retrograde wire intubation?
Scalpel cricothyroid notch and made an incision. And
Incision.
in the nick, sir.
Okay, or you can use your toy needle and then introduce. Yeah, how do you direct the toy needle? So first you have to do the airway blocks. You have to do. It is very important. So you can give some amount of sedation, and before that an anticholinergic to the patient. And after that only you will see that the patient is in a sniffing of morning air position. What is the sniffing of morning air position?
Flexing of cervical spine and extension. Atlantic.
Flexion of the neck and extension at the Atlanta-occipital joint. That is what is called as sniffing of the morning air position. Now you identify the cricothyroid membrane. Now what you have to do is you have to use your toy needle. Before that, you can locally anesthetize skin there and use a 18 gauge needle to just produce a opening there so that your blunt tipped toy needle can be introduced through and through. Otherwise, you'll not be able to push the toy needle inside because it is not sharp. It is a blunt. So with an 18 gauge needle, first you introduce it a little bit up to the subcutaneous plane. Then through that, you have to introduce your toy needle. But to the toy needle, you attach your lidocaine or saline. If you are not blocked the laryngeal injection, now you can give the translaryngeal injection using your toy needle also. So you can use a lidocaine. So okay, now or saline. So you have gone and you keep aspirating as you are going inside. Perpendicularly, you have to go. So what you should aspirate? You should aspirate for air so that you know that your tip of the toy needle is in the larynx. Now you have to direct the toy needle slightly anteriorly like this. Why you should direct it anteriorly?
So you have to take it, pass the guide through nose out.
No. Why should you direct it anteriorly? Now you had gone.
Injures.
Now just above the your needle, when you have introduced perpendicularly, will be the vocal cords, because it will be attached to the anterior posterior surface of the thyroid cartilage. You are just below the thyroid cartilage, isn't it? So once you make it slightly anterior, the toy needle or more cephaloid directed, so it is directly will be in between the vocal cords. Now you introduce your any guide wire you can introduce. So either you can use your even epidural catheter also you can introduce. And if you are keeping the patient in sniffing of morning air position, it comes out through the nostril. Once it comes out through the nostril, so now you take out the toy needle and now you have to fix the guide wire at the lower end where it has entered through the cricothyroid membrane. You can apply an artery forceps. And now you have to railroad your endotracheal tube through the or over the guide wire. That is what is retrograde wire intubation. Even what there are modifications are there, like you can first pass a airway exchange catheter because it will be more stiff. It can easily go through. Once you know that, and you attach your ETCO2 to that airway exchange catheter, and then see if you can get the ETCO2 easily. Now you know that it is inside the larynx. So over that, you can introduce an endotracheal tube. So that's how this is a very important technique, and you should always be knowing this particular technique. I still remember one of my students. He had a airway with a real difficulty because there was a tumor inside the oral cavity. So they had prepared for tracheostomy. So he rang me up and then asked me, sir, how to do retrograde wire intubation. So on phone, I started, telling him what all the things stepwise. And within, 3 or 4 minutes, he could get the tube inside the trachea. so they could avoid tracheostomy. So he was actually thrilled on phone only. He was, so much of happy and this thing feeling he was, bringing out on the phone itself. So because first time he had done on phone instructions only. So that is how, this particular technique is invariably asked for you in the exam, retrograde. It was called as retrograde intubation, but it is not retrograde intubation because you don't intubate retrogradely. You are intubating anterograde only over the wire. That is why it is called as retrograde wire intubation, because the wire is introduced retrogradely, and over that you are introducing. So that is one of the very important things you should always know about. The other important thing is about the blind nasal intubation. So in the blind nasal intubation, again, you prepare the airway and you keep the patient in sniffing of the morning air position, and you take a smaller tube, ideally a red rubber tube with a high pressure cuff would be ideal, because the low pressure cuff is slightly bulkier. High pressure cuff is very close to the outer surface of the tube. It easily passes. Or you can even use your armor tube. That also is highly flexible. It can easily pass. And you have to keep your ear on the proximal end of the endotracheal tube. Keep listening to the patient's breathing. And you are, introducing it very gradually, very slowly when the patient is taking deep breaths. So you ask the patient to take deep breaths. As he is inspiring, you are introducing. Because when he is taking a deep inspiration, the tube itself can be pulled towards the larynx. So once you know that it has entered, that means sufficient length has gone, and still you can hear the same intensity of the breath sounds. Now you know that you have entered into the trachea. So that is one of the methods. So suppose you are able to hear the intensity of the sounds very good. Suddenly the sounds disappear where the tube can be.
Esophagus.
Yeah, it would have gone into the esophagus. It's freely going, but sounds have disappeared. Now you have to make the patient to have more extension of the neck. Now again you try. Suppose you are going, but you are getting an obstruction. And outside you can see a bulge as you are trying to push. So where it can be, the tip? Yeah, piriform fossa. So it has gone like this, and then it is hitting the piriform fossa, the opposite side. Now you push the larynx towards the same side. Now, so that you make the axis of the vocal cords or glottic opening in the axis of the tube what you are passing. So these are some of the things they'll be asking you about awake blind nasal intubation. Suppose in children also you can do awake intubation in a child with temporomandibular joint ankylosis. There you use your, instead of awake, you can induce the child with sevoflurane, and through one nostril, you keep the your nasopharyngeal airway up to the the larynx, sorry, up to the upper part of the nasopharynx, and then continue to give the anesthesia. That is, the child can continue to inhale sevoflurane, and through the other nostril you can go. Or to the endotracheal tube itself, you can connect your circuit, and you hold your bag in your mouth, in your hand, and you can feel the the movement of the bag as you are going. So when sufficient length has gone and the bag is still moving very well, now you know that you have entered into the larynx. So these are some of the very important things about awake intubation. So you have to know about these things. So this is anticipated difficulty airway. Sometimes you have induced, but suddenly you may have an unanticipated difficulty airway. So you may not be able to mask ventilate. If you are not able to mask ventilate, can I give non-depolarizing or depolarizing muscle relaxant, or I should not give?
No, not give.
So you should not give any non-depolarizing.
How about depolarizing succinylcholine? What is the present thinking? Now the present thinking is, if you relax the patient, muscle, skeletal muscle relaxation, if you do, then mask ventilation will become easy. Because once you relax, you can hold the mask properly. So that is what you can still give. The algorithm is you try to mask ventilate, you're not able to ventilate, you give succinylcholine, and then try to ventilate. Probably you may be able to ventilate. So if you're not ventilating, you're not able to ventilate, you can definitely try for a laryngoscopy. And if you are able to visualize, you can intubate or wake up the patient. And then afterwards, you can call an experienced anesthesiologist and you can manage. So in any difficult mask ventilation. Okay, so that is one of the things which you should always know. Otherwise, unanticipated difficult airway, what is the algorithm? What is step 1, step 2, step 3, and step 4?
So first step is call for help. Sir.
No, you are able to ventilate and you are done a laryngoscopy, you are able to visualize, you intubate, successful, fine. But you are not able to visualize any part of the larynx. Now, what you do? The next...
we'll check for whether mask ventilation is adequate.
Okay.
Then we can go for supraglottic airway device.
Yeah, but you don't check for mask ventilation is adequate or not. You would have checked that before only. Before laryngoscopy, you would have done that, isn't it? So the second step is definitely you can use a supraglottic airway device. And if you are able to ventilate properly, fine. So you can manage the airway and even you can intubate through the supraglottic airway device if intubation is really required. Suppose you are not able to ventilate the patient with a supraglottic airway. What is the third?
Like mask ventilate is possible or not, we have to check, sir.
Suppose
if mask ventilation possible, we have to awake the patient.
Wake up the patient and you can call for an expert anesthesiologist and you can try to, or you can postpone the surgery also. Suppose you cannot intubate and cannot oxygenate with
front of neck access, like surgery.
Then you have to, there should not be any hesitation in going in for a front of neck access. So this is the DAS guidelines and even IDA. And throughout, it is very important to oxygenate the patient. You can continue to oxygenate the patient with a nasal oxygen, 10 to 15 liters, or even you can use Thrive. So that anytime the patient should not become hypoxic. Okay, so these are some of the things, some of the questions which you can be asked regarding difficult airway, and even all these supraglottic airway devices you may be asked different. How do you classify? What is first generation? What is second generation? What is third generation? So many questions can be asked about video laryngoscopes, supraglottic airway devices when you have a difficult airway as a short case. Okay, so we have discussed, I think, what is the time now? Almost just about 4 minutes are left with. So any doubts regarding management difficult airway?
Like on nasal, like fiber optic, we are placing at the level of perineum.
Pardon?
Fiber optic, once we are inserting, we will place at the level of perineum. And we have to rail out the ET tube. That time we will anesthetize or without anesthetizing, we will rail out the ET tubes.
No, you would have nebulized the patient first. And either after even nebulization, you can even go for spray as you go technique. That will produce more cooperation of the patient. So you mean to say that you give anesthesia, regular
like we'll give muscle relaxant, and once if we are confirmed, we will...
Definitely you can do that. But in an extremely difficult airway, you don't give that. Because, by chance, you are not able to introduce the your endotracheal tube through the... Sometimes it will be a problem. Because, the epiglottis will fall down. So you'll not be able to introduce your endotracheal tube. So sometimes, or you have introduced, the tube may curl there because of the obstruction there. So that is why ideal would be to get the airway, and then afterwards you can do anything. You inflate the cuff, you can do. So, but many people, what they do is, once they can visualize the carina, in order to make smooth introduction of the endotracheal tube, they just give propofol and afterwards they introduce the tube. Okay.
Chat box on question is this.
Pardon?
In chat box on question is this.
What is any question?
Sir, can we comment about Mallam-Patti class if mouth opening is restricted?
So definitely there is no point in talking about Mallam-Patti. You just say that Mallam-Patti examination Malampati test has, I did not do the Malampati because the restricted mouth opening. You can just tell that, or you can write down in your case sheet only. Because restricted mouth opening, there is no question of going in for a Malampati classification. You will not be able to see anything at all unless the patient opens his mouth sufficiently wide enough for you to see the pharyngeal structures. Because your basic idea is to visualize pharyngeal structures. And that is what is very important. One more question I just want to ask you is, suppose the patient is not able to sit. Can you do Malampati? Can you do Malampati in the lying down?
Extended Malampati.
Pardon?
Extended Malampati we have, but
not extended Malampati. There is nothing called as an extended. Now, can you do the Malampati test or not? Patient is not able to. Okay, one question that was asked is restricted mouth opening, you cannot do. But patient is not able to sit.
You can't do, sir. You can't.
No, because they have done studies again. These are the questions must have been raised long back. They have done a lot of studies. They have compared same patient sitting. They have assessed the Malampati scoring and making the patient lying down and asking the patient to keep his head in the neutral position and asking him to completely open the mouth, and your eyes should be at the same level of his oral cavity. And you look for, even in sitting posture, your eyes should be at the same level of the oral cavity. And you can do, there is no difference in the sitting posture or lying down posture. Only thing is, you should not phonate. Phonation will, spuriously will make a Malampati scoring easy. So you should not ask the patient to phonate. That is one thing you should always make sure.
So
Okay,
one more doubt. So, like, if third generation supraglottic airway device, if only bus come any other devices.
Now this, the third generation means you should be able to intubate also. And the second thing is it also should give you protection for aspiration also. That is what, if you gives only protection for the aspiration, then it is a second generation. If you are able to intubate also, it is third generation. So Buska mask is one thing. Second thing is you have blockbuster LMA. Now it is called as a third generation because the advantage of a blockbuster LMA is it has got a very good preformed curvature, and the curvature is so good that the aperture will be opposing the laryngeal inlet. That is one thing. And along with this particular blockbuster LMA, they provide you with a specially designed endotracheal tube, which has got a Parker. It has a sharp tip, flexible Parker tip, sharp tip, like a pen, Parker tip, the nib of the pen. So it is like sharp one, and it is the tip is flexible, so easily it can pass through the glottic opening. So that is the advantage of blockbuster. So it has got two on either side for introducing your gastric tube and also for doing suctioning. And also it has got on the back of the posterior aspect of the aperture, the mask, it has got a small reservoir for any secretions to collect. So it has got multiple advantages. So that is why blockbuster is also called as a third generation element.
Like one more question they've asked us.
Okay.
How to find degree of moments for neck extension and flexion and normal angle value? Like how to assess subjectively?
How to assess the neck extension?
Yes, and flexion and normal angle.
No, you are talking about that neck extension. You ask the patient to keep his head neutral, keep the mouth half open like this. So you keep a scale all along the upper alveolar margin or upper teeth margin. Now you ask the patient to keep the mouth open, and you also keep that scale like that only, and ask the patient to extend his head completely. And now the upper alveolar margin will also go up. So put another scale. So it will be like this. So keeping these two scales, you have to measure the angle between these two, and it should be more than 35 degrees. And simple way is I told you that
Seats.
you ask the patient to look at the ceiling without moving his eyeballs. If he can able to see the ceiling, it is more than 35 degrees. Good. We had some questions at least asked at the end. So any more doubts? So if you still have, because have any more doubts, you can definitely ask in the next week class. So anyway, next week you people will not be there, but you can always, you are not presenting, but you can always be there at between 5 and 7. And also you can listen to or watch the video later also. So, but if you have any doubts regarding anything, need not be of that day's whatever the discussion. So all these days, whatever we have discussed on many of these, if you have doubt, because now you'll definitely get more doubts as you study more intently. You definitely every day you will be getting. So those doubts also you can just ask. We can clear those doubts also. So just don't hesitate in asking the doubts. Okay, so next week what cases will be? Is it Thursday, Friday, Saturday, or only Friday, Saturday? Mukhtar is.
Yeah.
Pardon?
Use your recording.
Yeah, Mukhtar, next week we
Uh,
going to have 3 days or 2 days?
So next 2 days, sir. Saturday and Friday and Saturday.
Friday and Saturday. Okay, fine. So what other cases? Liver also to be discussed.
Yes, sir.
Liver
One
and
second.
other small short cases.
Hello.
Yes. Yes, Mukhtar.
Sir, short cases only will be continuing, sir. So
Okay.
Thursday mostly we'll not have because the festivals. So
Okay.
so we'll be doing on Friday and Saturday. I'll send the schedule in few days to you, sir. By Monday, I'll
Okay.
send the schedule to you.
Okay. Thank you. Thank you so much. All the best
Thank you,
for
sir.
all the exam going students. Do
Thank
well.
you, sir.
Come out with flying colors.
Thank you.
Thank you, sir.
Thank you so much. Thank you.